All right. I think we are live. Welcome, Dr. Sista. How are you?
Good. How are you, Dr. St. George?
I'm well, thanks. I'm sitting here with my coffee at home, and it's unfortunately snowing outside, so I'm a little disappointed that the first day of spring comes in with snow. How about you?
Yeah, I think it's rather appropriate given the winter we had uh,
All
that
right.
we're
Nothing
celebrating
against
the
that.
first with snow. It was
So
it was a bit shocking. Yeah,
it was a little bit shocking this morning. I agree. So, but
yeah.
what better weather to have a conversation about DVT? That's why we're here today.
I I agree.
I am very excited to have you with us today. Dr. Sista is the head of the Thrombosis Center here at Weill Cornell Medical Center, and he is here today to talk to us and answer all our questions about DVT and the changing paradigm in the management of DVT. So let's get right into it. Quickly, tell me a little bit about yourself and just a little bit about the Thrombosis Center so we all know what it is you do.
Sure. So, I started off in 2011 at Cornell with the charge of, starting to build up the endovascular deep venous practice in our division of interventional radiology, and that went well in terms of joining the appropriate study and starting to get referrals for DVTs. But what I noticed most about this was that a lot of these patients were not aware of all of the potential options for DVT care, and often didn't have good follow-up when they were either discharged from the ED or the hospital. And I know that this has been a issue across the country, especially with VTE care, is making sure that they get the appropriate follow-up. And so that was kind of that was kind of the background that led to the thrombosis clinic on the Upper West Side, which is it's under the umbrella of the Comprehensive Vein Care Center up there. And the whole goal is to make this transition from an inpatient to outpatient setting as safe and effective as possible, and give people all of the uh, give people the potential to really have the best possible outcome from their VTE event.
Yeah, so this is music to my ears as an emergency physician who is constantly worrying about whether or not patients are getting the right care once they leave my department. We have started sending patients over to your clinic recently with the new guidelines and the protocol we worked out, and I'm very excited to continue to send patients your way for sort of optimal management and care. Most of us in emergency medicine, I think in internal medicine as well, sort of saw the practice of DVT care change rapidly over the last few years from something that was an automatic admission, start on heparin, switch to Coumadin eventually, and then send home, and no real further care other than several months of oral anticoagulation. Now we're seeing endovascular interventions, and we're seeing new novel oral anticoagulants, and we're seeing all sorts of options for treatment and care which we didn't have before. So let's start with the sort of conventional therapy, going from heparin to low molecular weight heparin to the novel oral anticoagulants. What's your take on all this?
It's a very exciting development, as everybody in the VTE world is aware of. We obviously don't have the history we have with Coumadin, and with the low molecular weight heparins and heparin, and we certainly need to build post-marketing data, and make sure that these are actually the kind of quote-unquote godsend they are. But it would seem that for most VTE patients, that these novel anticoagulants are really doing the job. They're convenient. They seem to have the right safety profile, and the same and non-inferiority to Coumadin. So far so good. It would seem. Now we have to figure out what to do with patients with renal insufficiency, certainly, and the elderly, especially those at risk for a GI bleed. But hopefully, as we gain experience with this, we'll continue to refine our algorithms.
Yeah, so let's talk about that a little bit. I think any doctor out in the community or emergency physician who's going to send home a patient on a therapy of some kind, I think the first question they ask is it safe for my patient? Um, and is there any literature so far showing that at least there's equivalence, or at least there's safety? Are we doing the right thing by sending these patients home, and are we going to have to worry about them?
Well, I mean, if you look at things like the Einstein study, and I think you have the systematic meta-analysis that in the showcase column here.
Yes, for those of you who are going to watch this, there's a showcase column, and up here I've thrown up a bunch of different items that you can link to, and one of those is this outcomes for acute venous thromboembolism study that we're talking about now.
That those components that people are concerned about, efficacy and safety, seem to be covered for rivaroxaban and most recently apixaban as well, and it seems to be a class effect that at least preliminarily, I think it's reasonable for you to say that this patient who has normal renal function and a low risk of bleeding is going to be just fine on one of these novel anticoagulants. And in my preliminary experience, that has been true as well. One of the cautions that I think we need to really keep in mind is that these are not Coumadins, so they don't stick around in your system as long. So one piece of information or education, especially from a discharge standpoint, is emphasizing the importance to the patient of taking their dose. That is where we've seen probably the most failures, and is in recurrent VTE in patients that all of a sudden stop their dose. And there might be some thought that they actually are not just not on anticoagulation, but might be slightly prothrombotic in that setting. So that the emphasis on being diligent with them and taking their dose is, I think, very a key part of the novel anticoagulant.
All right, that's very, very interesting. I think I did not know that, so that's a new piece of information for me. What in terms of our protocol, what dosing are we using of rivaroxaban?
So we are basically saying for patients with a GFR that's greater than 30, and most commonly greater than 60, that we are going to be using a dosing strategy of 15 BID for 3 weeks, followed by 20 Q day. That's what they used in the Einstein trial. Now, the question of what exactly you should prescribe as an ED physician all depends on the type of follow-up that patient's going to get. And that's where I think we come in. So if you're most comfortable with starting perhaps a week of rivaroxaban, then we can very easily see that patient in our thrombosis clinic within 5 days, probably more likely the next day. So very rarely will we not be able to see somebody within the next couple days after discharge. I think the only exception would be a Friday night or a Saturday night, when we'd be able to see them first thing on Monday.
So that's huge, right? I mean, I think that even though there is evidence or literature to support that this is a safe option and that this can become standard of care and that emergency physicians should be comfortable prescribing this, I think none of us are comfortable with the idea of prescribing 2 or 3 months of rivaroxaban and sending a patient out with no follow-up.
Right.
So let's also then talk about patients who are not a candidate for the novel oral anticoagulants like rivaroxaban. You already mentioned one, which was renal insufficiency.
Yeah.
So perhaps checking creatinine, or at least screening for any renal dysfunction prior to the prescribing.
Right.
You mentioned elderly already, which I think is really important, right? Patient who's a fall risk.
Yep.
May not necessarily be a candidate. Are there any other red flags or people that we shouldn't be prescribing these to?
Yeah, I think just to get a little bit more into the GFR issue, I think a GFR less than 30, we have to be careful managing as outpatients, because we don't have great bridging therapies. For example, I don't think we're going to, given that there is renal clearance for the novel anticoagulants, nobody is comfortable really prescribing novel anticoagulants for people with GFRs less than 30. So the question is, is there a way to bridge these patients to Coumadin as an outpatient? And really our options are kind of limited because Lovenox sticks around as well, as we know, in patients with renal impairment. And so that kind of leaves unfractionated heparin as the candidate to bridge these patients to Coumadin. Now, while you can give subcutaneous heparin, unfractionated, it's very difficult to find pharmacies that actually dispense that. So the patient with a GFR less than 30, it may be the type of patient, especially if they've got that combination with being elderly and not having good placement, and that's the patient that really may need to be admitted and transitioned from an inpatient then back to an outpatient once they're stably on Coumadin.
All right. Well, that's great. So that's actually a great segue into my next question, which is which are the patients that need to be admitted still to the hospital? I think that's that one you just mentioned, which is renal insufficiency, someone with a GFR less than 30. They're not going to get low molecular weight heparin. They're not going to get novel oral anticoagulants. So we're stuck with the good old-fashioned heparin drip, I believe.
Yeah. Well, there are a couple things I would say that would warrant admission. First, if the patient has a pulmonary embolism, I think there is literature out there talking about the type of PE that you can actually consider discharging from the ED. I think we're not quite at that stage as far as our own comfort level. So certainly a concomitant PE, I completely understand the desire to admit. Although, there are some PEs that are, if you put somebody on anticoagulation, they're going to do very well, even as an outpatient, and you might be able to spare them. But that's one thing that I would say is probably a reason for admission, at least initially, just to make sure they're stable and they're not going in the wrong direction from their PE. I think from a DVT perspective, if somebody's got really bad swelling, really bad pain and swelling, and you think that they're not going to be able to manage their pain, they're not going to be ambulatory, they don't have sufficient support at home to really take care of their leg, and they just can't walk, basically, that's that bad, that's another candidate for admission. And then obviously if they have phlegmasia cerulea dolens, so limb-threatening venous obstruction, that patient needs to be urgently, I would say emergently evaluated by a venous endovascular specialist.
So I think that's great. You're leading right up into my next question for you, which is wonderful. But also, I think it's very important to remember that because the pendulum is starting to swing towards DVT as being managed by outpatient therapy with good follow-up, doesn't necessarily mean that pendulum should swing 100% all the way in the opposite direction it was 10 years ago. Getting pushback from admitting services, why are you admitting this DVT? I think it's very important for us as emergency physicians to understand the criteria and who we're admitting and why. So, severe pain, severe edema and swelling, cerulea dolens, phlegmasia, all of the signs that this is not just a DVT that's causing minor problems, but is really affecting the overall circulation of the lower extremity, I think are all reasons to still admit patients. Would you agree?
I would agree, and I think along with that admission, it's the sort of thing that we as interventionalists would like to be notified of earlier rather than later. So that's the type of patient that we can start planning. We will take a look at it, and at some point in our conversation here, we might talk a little more about catheter-directed therapy, but we can at least advise on the appropriateness of a more urgent procedure in those circumstances, and especially just if the patient's a low bleeding risk and can tolerate catheter-directed lysis, we might be able to get them better quicker and prevent long-term complications potentially. So at least us stratifying that patient on either the ED visit or close in their admission to an inpatient service, having that heads up is very helpful to us and I think the patient.
Yeah, so this gets to the next big topic that I want to cover today, which is that I think there needs to be this was eye-opening to me when we talked about it not too long ago. But this idea that there are interventional endovascular therapies that are out there now that can have a huge effect on the morbidity of this disease. And I think there's not a lot of awareness out there about this, or making sure that we're picking up the subset of patients that might really benefit from this. So why don't we get into that a little bit, post-thrombotic syndrome and some of the morbidity and the epidemiology of it, and talk a little bit about what, give us a little bit of knowledge.
Sure, absolutely. So, as you know, Dr. St. George, the traditional thought process with DVTs, we just have to prevent the pulmonary embolus. That's really our goal of therapy, and absolutely that is the number one consideration. You want to make sure this person doesn't die from a pulmonary embolism. That's why we put them on anticoagulation. The problem is anticoagulation is ineffective at preventing what we call the post-thrombotic syndrome. And why do I say it's ineffective? Is because with a proximal DVT, I'm talking like an iliofemoral, maybe high femoral DVT, you have about a 40 to 50% chance of developing the post-thrombotic syndrome. Most patients so what is the post-thrombotic syndrome? It is a constellation of signs and symptoms. The signs being swelling, skin changes, and at its worst, venous ulcers. And the symptoms being things like leg heaviness, pain, claudication, itching. And you know, this really does affect quality of life for people. They sometimes are no longer able to go to work. Fortunately, the majority of people are in the mild PTS category, PTS meaning post-thrombotic syndrome. Subset, maybe 10 to 20% are in the moderate, and about 5 to 10% are in that severe category with venous ulceration. But given how prevalent this is and how much it costs the healthcare system, the NIH actually invested in a very, very large multi-center trial called the ATTRACT trial, which some of you might have heard of. We enrolled 16 patients at our site, and basically what it was trying to figure out is if we use catheter-directed therapy up front when these patients are acutely clotted, and we actually remove that clot, can we prevent the post-thrombotic syndrome 2 years later? And that trial just finished enrolling 692 patients that were randomized to either receive the catheter-directed therapy or anticoagulation alone. And so we'll know the answer to that hopefully in 2 years. Right. So that's probably how I would start off the discussion of PTS.
Yeah, so I mean, this is mind-blowing to me, right? I mean, I think as an emergency physician, I was taught, you know, the reason we treat DVTs, again, is prevent PE.
Yeah.
And I honestly very rarely thought about the disease itself, which is the DVT, and what the consequences of that can be for patients. I mean, we see it all the time in the emergency department, people with prior DVTs who have chronic venous stasis issues, painful legs, difficulty walking. You know, and it's mind-blowing to me that we're not spending more time sort of identifying these patients who are at risk and getting them somewhere where they might actually get therapy, which could change their lives. You know, if it were me and I had a DVT, I would potentially want this therapy, particularly if I were having really bad PTS symptoms. So, you know, as an emergency physician, which patients, you know, particularly would you say to us or say to me, hey, I recognize these signs and symptoms and get these patients potentially to somewhere where they can get therapy?
So as we all know, one of the most important things for us as interventionalists is to do no harm. So we need to pick these patients appropriately. So, you know, somebody like you, if you came in with a DVT, you have a low risk of bleeding and you have a very high functionality. So we'll have a much lower threshold to intervene on somebody like you. Somebody who's older than 75 has a history of GI bleeding, has a history of intracranial mass. Somebody who's at high risk, we have to really make sure that their clot is either progressing, life-threatening, limb-threatening, to really justify, you know, preventing a morbidity 2 years later for the potential risk of a procedure where we're giving lytics. Now, granted, we give lytics in a much smaller dose than systemic thrombolysis, and we've really refined our techniques to improve the safety of this, but I think that's the first thing to think about. The other thing is, where is the clot? So if it's iliofemoral, this, as I mentioned before, has a pretty high incidence of PTS associated with it. So if you have a young woman who is just pregnant, who just had a DVT and it's in the iliofemoral and her leg is painful and swollen, and she's 35 and she's at high risk for developing the post-thrombotic syndrome, that might be a perfect candidate for us to go and try to get that clot out of there. I say that in the absence of the ATTRACT data, although there was the CAVENT study in Norway, which was a randomized trial that showed a benefit for catheter-directed lysis. There were some methodological problems, but we need that level 1 data. But at the same time, in the meantime, a person that's got a low risk of bleeding and a very proximal clot could potentially benefit from a catheter-directed lysis procedure.
Yeah, I think this is some of the stuff that's going on in the world of medicine, particularly in interventional radiology, is cutting edge and is the future, and the data is a little bit behind. But I certainly feel like this is a great topic to have a shared decision-making conversation with a patient, particularly if they're incredibly symptomatic. I know that I probably, if I were in that situation, I would probably say, let's do it.
Yeah.
But just to be aware that the data is still evolving, and that's why it's important, I think, to have early follow-up and a discussion with patients. That's one of the beauties of having the Thrombosis Center here at Cornell, is we have an opportunity to send patients to somebody who can have that discussion with them in a thoughtful way.
Right. And you also mentioned patients that come in with the post-thrombotic syndrome already, and then they get a recurrent DVT on top of that, and they're at risk for their PTS getting worse. We're actually treating people with established PTS with endovascular therapy as well. Patients that have had a prior DVT that's that caused their vein to shrink down and become basically nothing, and then cause venous hypertension in their leg, we can actually wiggle a wire through that old obstruction and open it up and relieve that venous hypertension with a combination of balloons and stents. And so the patients that presume that they had this painful swollen leg for the rest of their life actually may have an option. And then the other nice thing about opening up their circulation is they may be less prone to recurrent DVT. And interestingly enough, I'm just going to a new investigator meeting for a trial called the C-TRACT trial. So there was the ATTRACT trial, and this is the C-TRACT trial, looking at whether adding endovascular therapy to a comprehensive PTS treatment strategy can actually improve outcomes for these patients. So you're absolutely right. Interventionalists have been behind on generating the data, but thanks to Suresh Vedantam out in Washington University, who ran the ATTRACT trial and now is running the C-TRACT trial, I think we're going to have level 1 evidence for or against these catheter-directed therapies.
Well, I think that's another interesting category of something that I don't think about much, but I'm going to start adding to my practice. When people come in with chronic venous changes or pain and swelling in their leg, I will be asking them, have you had a DVT before? Maybe this is a patient, even 6 months or a year after having had their event, may be a candidate for endovascular therapy. I have to say that I love the fact that not only are you an interventional radiologist and doing all this endovascular therapy, but you also sort of manage the whole process and have people on the oral anticoagulants, and it's great to see such a comprehensive center that we can send patients to. We're extremely fortunate at Cornell to have this. Not everybody is going to have this, unfortunately, in their area. Do you have any suggestions for people who are out in the community who may have difficulty getting their patients to the right place? Any advice for them?
Yeah, I think that unfortunately we don't have these comprehensive VTE clinics, and it's one of the reasons that I and a couple of my colleagues, and actually you as well, Dr. St. George, have kind of collaborated on this initiative to try to really improve the comprehensive and longitudinal care of these patients. While these clinics don't necessarily exist, we hope to first of all be a model for that. But then I think for somebody in the community that doesn't have access to such a clinic, finding somebody in their general area that thinks about perhaps more aggressive strategies in the right patient, whether that's a interventional radiologist who specializes in deep vein care, a vascular surgeon, whatever the interventionalist is, getting in touch with them sooner rather than later, and considering some of these more advanced therapies is I think a reasonable starting point. And then if that person interacts with hematologists, then you start to develop the components of a comprehensive VTE follow-up. What we're trying to do here is make it all in one place and provide a nexus for all of these different connections that are, in my opinion, absolutely necessary for optimal VTE care.
Yeah, I think one of the reasons why I wanted to do this interview with you today was just for that reason. I think just starting to expand the perspective of practicing community physicians and emergency physicians, that perhaps there is a more comprehensive approach to VTE than just anticoagulation therapy. I think I think for patients too. I think if they're getting the pill and this pill is meant to treat their DVT or prevent them from getting a PE, and it doesn't cross anybody else's mind that there might be something more out there. And so the one last topic I did want to discuss, which you just mentioned, was hematology involvement. So we have the novel oral anticoagulants, we have endovascular interventions. When do hematologists, or when should a hematologist get involved in a comprehensive care for a patient with a VTE?
Yeah, I think to put it most simply, the lack of provocation is the #1 factor to look at. Somebody that's just had knee surgery, hip surgery, and has a DVT and is on anticoagulation and getting better, a clear provocation like that is pretty standard. 3 months anticoagulation and a reassessment at that time. Most patients in that category can go off of anticoagulation. However, the categories that I tend to get my hematology colleagues involved in are the unprovoked DVT, first-time unprovoked VTE, I should say. The one that's had recurrent DVTs, the one that's had a particularly severe venous thromboembolic event, the one that you're concerned might have an underlying malignancy. These are those are the sort of red flags that I will say, I'm going to send you to hematology. I'm in clinic once a week. I have a nurse practitioner in clinic 5 days a week. We typically send, out of the 11 or 12 patients I see on a Thursday, we'll typically send about 2 to 3 of them to hematology. So I think there is a filtering process there, but what I will say is that if I don't send them to hematology initially, we follow up with them over the course of the next 3 to 6 months. And if something funny develops along that time, I have a very low threshold to involve Maria DeSancho, John Chapin, Paul Bassiano, or Andrew Schaefer.
Right.
And they're on speed dial as well, so they know that, and I'm on their speed dial. So.
I'm sure they love having you on speed dial. So that's all good information. So I think that the big take-home point is that we should be asking the questions of why they got their VTE, and if it's unprovoked, then patients should probably get a hematology evaluation. I also have trouble. I had a patient the other day who ended up having a PE, and he'd been on a plane flight, but it was a 3-hour flight from Denver, and I was like, well, I didn't really think that was a provocative enough to me to say this guy needs to see a hematologist, or provocative enough to me. I'm sorry, the other way around. I thought 3 hours. Should I send this guy to a hematologist? Because that seems a normal person shouldn't get a DVT just sitting on a plane for a couple of hours. And then the other one I wanted to ask you about is, do you have any thoughts on things like oral contraceptives? So plane flights, I think, and oral contraceptives are 2 of these kind of slightly. We know they increase risk, but does that really count as provoked?
Yeah, I think those are good questions. The plane flights, they've become a softer indication. You have millions of people that are flying per day in these long flights, and not all of them are getting DVTs for sure. So to say that it's not, to say that it's a provoked DVT, I think deserves a little bit more exploration, like you're saying. If you ask Andy Schaefer, who's the former chair of medicine here, he kind of believes that there's no such thing as a provoked DVT. That somebody who's actually had a DVT, at least in that moment, had a higher risk for clotting than the general population for whatever reason. And we have our standard thrombophilia testing, but it may not have whatever small factor that person, that individual might possess. So I think that your concern about that particular patient is warranted, that there's more to the story. As far as oral contraceptives go, Maria DeSancho is a real expert in this, and she's had some real thought-provoking sort of discussions with me on that. So I think she's a believer that oral contraceptives and certain formulations in particular are really, that she would consider those provocations. One interesting study was, if you've heard of the May-Thurner syndrome, which is the compression of the left common iliac vein by the right common iliac artery, and it's kind of smushed between that artery and the vertebral body just behind it. If you have that and you're on oral contraceptives, you have almost a 10 to 13-fold risk increase of having a DVT than if you only have one or the other on board. So it seems like, from all indications, that there are certain types of oral contraceptives, and we've seen it in our practice as well, that are certainly a risk factor for DVT. And I think, and then you find that after you take them off of that oral contraceptive, put them on a anticoagulant, and you take that, they never take that OCP again, they're usually okay. So I do think that OCPs should be taken seriously as a risk factor.
All right, great. Well, I think we've covered a lot of information in a short amount of time. Just to review, it seems that we're saying that the novel oral anticoagulants in the right patients, ones that don't have renal insufficiency, ones who aren't fall risks or bleeding risks, can potentially be started on these medications and sent from the emergency department for early follow-up as outpatients. That endovascular therapy is an emerging process, but seems to have a great potential for reducing the morbidity of this disease, and that we should be thinking about it more often in our practice and when we're screening our patients. And finally, that not everybody needs a hematologic workup, but the ones that do are particularly the ones where we think that it was unprovoked. Is there anything else you'd like to add before we sign off today, Dr. Sista?
No, I just want to thank you for this opportunity to talk to ED physicians at Cornell and potentially at other places. And I think this is a multidisciplinary disease that is an important disease process to get in on at the beginning and try to grab a hold of it and understand that it's both an acute and chronic disease, and that it needs a coordinated effort between the people that have to interact with it acutely and those that need to guide the person through the rest of the disease after their acute part is taken care of so well by you guys.
All right, Dr. Sista, well, thank you very much. I do agree that medicine is a team sport, and it's exciting to have great players like you on the team helping us with these difficult patients and making sure they get great care. I look forward to talking to you again soon about issues involving VTE. Thanks very much for your time.
Thank you.